In our last few minutes, we have some questions from the audience.
Good.
Some of which I think we got to. Such as, in which patients are we using obinutuzumab in place of rituximab? And I think we got to that. The Catalan data, I think, was supported, and perhaps the gallium data, we talked about those. Maintenance. Maintenance therapy in follicular lymphoma, you said you're not a maintenance fan.
I'll be the kind of tiebreaker, I guess, or the voice of reason. I use it in select patients. In patients who only achieve a PR, in other words, they're responding, but we have a little bit of disease left, and we have 70% of tumor burden is gone. I often will add an extended maintenance phase, and that's based upon the prenatal data showing that there was a higher percentage of patients
I do think that
CR.
with
Now,
standard
I also, and this is
there are a group of patients who are at risk for relapsing early.
not a lot of data for this, I'll just tell Bruce, but I do think that with standard chemoimmunotherapy,
rituximab maintenance.
there are a group of patients who are at risk for relapsing early, the high FLIPI patients.
Now, what you're doing with maintenance is you're trying to clean up failure.
Sometimes we'll add
That's
rituximab
essentially what I
maintenance
said. So
Yes.
why not
in a
switch
patient who I
to a
think
different
is at
drug
high
at that
risk for
point?
early relapse.
If they got a positive
Now,
test,
what you're
if
doing
they are
with
still
maintenance is
MRD
you're trying to
positive,
clean
you
up
have the same
failure in
assay
resistant
nuclear
patients.
response. Wouldn't
That's
that be
essentially what
time
you just
to
said.
switch to
So
something
why not switch to a different drug at that point? If they got a positive
No,
PET,
because I
if
think-
they are still
I
MRD
understand
positive.
the argument. However, again, we saw, even without change in the antibody, that there was a higher percentage of patients who will achieve CR. In other words, they were still deriving benefit from an anti-CD20 long-term. And again, the counter argument is that the patients that did not achieve a remission in the first 6 cycle, or are the patients who have clones that are CD20 resistant or have some resistance mechanism to the chemotherapy that you gave them, and again, switching to an alternate therapy would be the right choice. But I'm not clear, at least in the first line, that those patients have yet declared themselves. I think that, again, there are a group of patients who relapse early and are refractory to the first line or the second line, and those patients definitely need novel strategies. But I'd like to, this is maybe wishful thinking, I think that there maybe still is
You're
a group
still
of
young.
patients who, with maintenance therapy, you can get them in a deep remission and achieve a prolonged disease-free interval.
Okay. Next question, how are you treating older patients in the salvage setting?
It's a good question. So again, not all patients are created equal. Some old patients really fit and playing tennis every other day and traveling, and so those I treat them like anyone else. They get BR if they haven't been exposed to it before. The more frail patients, they usually end up getting single agent, either rituximab or sometimes in combination of lenalidomide, depending on how much they can tolerate that.
Yep. I think I totally agree. I think it also really depends on the length of their last remission. So many times in patients who are elderly and they have a remission lasting really more than 24 months, I'll just give them CD20 again. And many times you can really get quite a lot of disease control just by re-exposing.
How do you
the
give it
CD20s.
again?
I usually do 4 doses and stop. I don't usually add maintenance. And that's it.
Okay. In the early relapsers, we've already talked about the national trial, we're doing what we do in the clinical trials. What's the role of transplant in the early relapse
It's a good question. I don't know. And again, and I don't think people should start jumping into using transplant as standard of care for these patients.
Should not.
Outside the clinical trials, because we don't know if this will change the outcome. I think if there's a clinical trial that is looking at the role of transplant in these patients will answer a specific question, I think it's a great idea. But I don't think it's a standard of care. Just because you failed early on, I'm going to intensify therapy and I'll give you more chemo and then high dose therapy because I think this will do you better. I think we may be shooting ourselves in the foot. And then
Do you think this is a setting where CAR T cells may come into play?
I think absolutely. I think that, as Anas mentioned, it's unclear. Well, let me back up a little bit. There are patients who, I think we've all seen in practice, who become chemorefractory in short order. And unfortunately, despite the activity of most of these novel agents, most of them, as we've talked about, have remission times lasting a year at best. And those patients are still at high risk of dying of their disease. So patients that relapse in short order within the first couple of regimens, novel therapy is really just prolonging remission. It's not curing anybody. The CR rates are very, very low. So in those patients, like Anas, I usually look for a trial that includes stem cell transplant because there is fairly decent data from both allogeneic as well as autologous transplant that durable remissions can be obtained with that type of consolidation. In fact, there's data from, I think this was from consortium data from using transplant in patients that were refractory to 2 lines, and the 10-year remission rate's over 50% in those patients. Again, select group of patients that could tolerate transplant,
And
patients
had
that
very little
responded.
disease.
But I think that in the absence of a novel combination or a clinical trial which is going to change the natural outcome of those patients, I still tend to send them to transplant.
This has been a great discussion. We hope that you found the information to be valuable to your clinical practice. And we welcome your feedback on what we covered here today. Please send your suggestions to onclivenn@onclive.com. Thank you all for watching the OncLive News Network live broadcast from MJH Studios. And my particular thanks to my good buddies here, Anas and Nathan.
Thank
Have
you
a
very
great
much.
day.